So thanks for the introduction. So unruptured intracranial aneurysm is a prevalent disease, about 3% in population, and it's a major cause of hemorrhagic stroke. And current clinical management is based on size and location. For example, the intervention is normally recommended if the size is more than 7 millimeter. However, there are a considerable amount of small aneurysms also rupture. That means we need to find some new markers to improve the current model. While the wall enhancement on black blood MRI is a novel marker of unstable aneurysms, it has been observed more frequently in ruptured, symptomatic, or fast-growing aneurysms. So the intracranial aneurysm can cause symptoms including the vision loss, headache, which has been considered as a sign pre to rupture. And the previous studies of symptomatic UIAs is limited in small sample size, mostly smaller than 30. So it lacks the power to determine whether the enhancement is an independent predictor, because mostly the symptomatic aneurysms are larger. And also there are many enhancement characters, and the previous studies are very heterogeneous in this. They are not described in very detailed, for example, the enhancement degree, enhancement pattern, and so on. So the aims of our study is to first investigate whether enhancement is an independent predictor of symptoms in a large cohort of patients with multivariable analysis. Second, to determine which enhancement character is the strongest predictor. We include 147 patients with 174 UIAs, and half symptomatic and half asymptomatic. We define the symptoms related to aneurysm very carefully, including the 3 types. First is a sentinel headache, means acute headache on the ipsilateral side of the aneurysm within 2 weeks prior to admission. Second is a chronic or recurrent headache with a marked improvement of these symptoms after treatment of the aneurysm. Third is the cranial nerve deflects, including these several types. And we also collect the patient clinical information, including hypertension, smoking, and so on. The patient was scanned by pre- and post-gadolinium T1 weighted black blood MRI 3T, including both 2D and 3D sequences. We defined the degree of enhancement into 3 grades by 2 radiologists. Grade 0 means no enhancement. Grade 1 represents enhancement less than that of pituitary. Grade 2 is equal or greater than that of pituitary. And area of enhancement defined as 0 is none. Score 1 is focal enhancement. Score 2 is diffuse enhancement. And score 3 is a complete enhancement. We also measured aneurysm morphological parameters derived from 3D DSA, the size, aspect ratio, and irregular shape. And we performed the univariate and multivariate logistic regression analysis with a mixed effect model. Now let's see the results. In the 87 UIAs with symptoms, there are 6 oculomotor nerve defect, 11 visual activity loss, and 31 acute headache, and 33 chronic headache, and 8 other symptoms. We found very good reproducibility for the aneurysm wall enhancement characters with all kappas more than 0.8. And we can see in the left figure the aneurysm size of the symptomatic aneurysm shown in yellow. Shown in yellow here is much larger than the asymptomatic patient. Average size is 11 millimeter compared to 7.6 millimeter. For the locations, there are no big differences in the IC, PC, or VBA. Then for the enhancement grade and enhancement area, let's look at the left first. As shown in yellow, the symptomatic aneurysm has much more enhancement grade of 1 and 2, while the asymptomatic aneurysm mostly is no enhancement grade 0. While for the enhancement area, it's a similar trend. The symptomatic aneurysm has more diffuse or complete enhancement, while the asymptomatic aneurysm have no enhancement, or mostly for the enhancement, asymptomatic aneurysms are mostly focal enhancement. So we found there is a significant difference in the enhancement degree scores and area scores with very significant statistical significance. Then when we performed the multivariable analysis, we found only size and enhancement area are independent predictor of symptoms. We performed the ROC curve to differentiate symptomatic and asymptomatic aneurysms. We found the area under curve values. For the traditional factor, the size, we can find the line is here, AUC 0.69. Then for the enhancement yes or no, which has been performed by many other studies, the value is 0.8. While we do the aneurysm enhancement degree, it improves to 0.84. And when we use enhancement area, it further improves to nearly 0.9. So we believe the enhancement area is the best predictor. Now let's see some cases. This is a 66-year-old woman with persistent headache. You can see this is a GINT SE aneurysm and pre-post blood MRI. Shows very clearly strong enhancement, grade 2, and complete enhancement. And this is another patient, 71-year-old woman with acute headache and vomit. And this is the MC aneurysm. And pre and post phase, we can see there is only a minor enhancement, focal enhancement. Degree of enhancement is 1. So in conclusion, we found that enhancement area is the independent and the strongest predictor of symptoms. We use a large cohort, allows the control of many of these confounders. We also perform a comprehensive analysis of enhancement characters. And the enhancement area as the strongest predictor maybe can be explained by it shows the different pathology subtypes. For example, the histology study shows the aneurysm wall can have atherosclerosis or development of vessel or inflammation cells. And in the future, the 3D quantitative analysis of enhancement may provide additional information. And future histological studies and longitudinal studies are needed to confirm these findings. So in conclusion, we found the aneurysm wall enhancement area is a strong and independent predictor of symptoms of UIAs. And thank you for your attention.